Hello, my name is Skylar Webb, and I will be presenting the disease process of ductal carcinoma breast cancer in order to help educate those around me to learn about this disease. In Cancer Society, ductal carcinoma can be defined as a cancer that starts in the epithelial cells that line the organs and tissue of the body. In this case, ductal refers to the milk ducts found in the breast. There are two types of ductal carcinoma. One type is in pseudoductal carcinoma, and it is a precancer that has not spread to the rest of the breast tissue and is often referred to as ductal carcinoma in pseudo or DCIS. The other type is invading or infiltrating ductal carcinoma, also referred to as IDC, which describes when the cancer cells have invaded other parts of the surrounding tissue and are no longer just in the milk ducts. DCIS can be called stage 0 breast cancer or an intraductal carcinoma. The objective of this presentation are to understand the impact on the U.S. population, the etiology and risk factors, pathophysiology, clinical manifestations and complications, treatment, and evidence-based nursing practice of the disease process of ductal carcinoma breast cancer. According to the American Cancer Society, middle-aged and older women are usually diagnosed with breast cancer, making the median age of diagnosis 62 years old. 1 in 5 new breast cancer diagnoses will be DCIS. However, this is not the case for IDC. An estimated 8 in 10 invasive breast cancers will be IDC, making it one of the most common types of breast cancer. Black women have a lower median age of diagnosis, being at 60, and a higher rate of developing breast cancer before 40 compared to other nationalities, and unfortunately have the highest death rate from breast cancer. It is noted in these statistics that Alaskan and Native American women have the lowest risk of developing breast cancer, and Asian and Pacific Islander death rates are the lowest. The American Cancer Society estimates for 2023 about 55,720 new cases of DCIS will be diagnosed. About 297,790 new cases of invasive breast cancer will be diagnosed in women. About 43,700 women will die from breast cancer. The chance of women will die from breast cancer is about 2.5% or 1 in 39. The breast cancer death rates have been decreasing steadily since 1989 for an overall decline of 43% through 2020. The American Cancer Society also offers insights on survival rate for women with breast cancer. These numbers are calculated over a 5-year timeline, and they are broken down into 3 categories. Localized means the cancer has not left the breast tissue. Regional is the breast tissue spreading to the surrounding structures such as lymph nodes. And distant means the cancer has traveled to other parts of the body such as liver and bones. The survival rates are as follows. Local 99%, regional 86%, distal 30%, and of course these are estimates and are calculated by when the cancer is first diagnosed and stage. These numbers do not account for remissions or triple negative breast cancer or inflammatory breast cancer, as those survival rates differ. In Tomlinson and Hansen's piece, the etiology of DCIS and IDC are still not clearly known. Researchers are studying the genetic predisposition of DCIS. They have found that there is a strong link between BRCA1 and BRCA2 mutations, but this is not seen in all DCIS patients. The number of breast cancer patients has increased subsequently over the years with the use of a mammography, or more commonly referred to as mammograms. Risk factors for developing breast cancer include increased exposure to estrogen, which in another piece by Delgado and Lopez, estrogen exposure can come from medications for multiple purposes. Most medications are commonly used for postmenopausal women and as oral contraceptives, as well as those who suffer from primary ovarian insufficiency. High extragenous levels of estrogen can also increase a woman's risk for developing breast cancer. This can be seen during times in a woman's natural reproductive life, such as their first menstruation, their first live birth, and at age which menopause occurs. As always with medical terms and medical diseases, alcohol use is another strong factor that can influence if you get breast cancer. and first-degree relatives. In Alcoban and Ferguson, breast cancer develops from DNA damaged or mutation influenced by exogenous estrogen. Sometimes DNA defects can be inherited in genetics, like the ones I mentioned before, or other times it just happens randomly. Histologically, DCIS starts as a discrete malignant cell that fills a space in the basal layer of presumably normal myoepithelial cells. As these cells grow, DCIS progresses into four broad types. Papillary and cryobryoform are the lower grade ones and take longer to transform into invasive cancer, or a solid and commendo types that are generally higher grade and commonly transfer into IDC. IDC tends to grow as a cohesive mass and appears as a discrete abnormality on imaging and in discrete lumps in the breast. The images that are on this slide depict what the cancer cells will look like under a microscope. The top one is a low-grade intraductal epithelial proliferation with cerebrioform pattern and microcalcifications. The bottom image is a high-grade intraductal epithelial proliferation with solid growth pattern, lobular extension, and focal necrosis. Clinical manifestations of DCIS include an abnormal breast exam and often is the start of DCIS. In Tomlinson-Hansen's piece, abnormal breast exams are defined as one of the following being present during examination: a palpable mass in the breast or axillary area, nipple discharge, skin changes, lumps, or abnormal lymph swelling. It is worth noting that not all patients with DCIS have a palpable mass, and it is often seen during diagnostic imaging such as mammograms. According to the American Cancer Society, skin changes can include templing of the skin to look like an orange. The skin can become red, flaky, or even thicker. Other physical signs can be nipple retraction, where the nipple starts turning inwards, and or breast pain and nipple pain. Breast exams can be done by a provider or the patient themselves. Diagnostics for this disease include various types of imaging and biopsies. The most common and well-known diagnostic for DCIS is a mammogram. This is a low dose of radiation X-ray that can detect DCIS before physical symptoms may occur. Abnormal findings in the mammogram may lead to further testing in women, but there are two types of mammograms. There is a 2D one, which is standard, and 3D, which is becoming more popular as it can X-ray those who have dense breast tissue. Next is an ultrasound. Although it is not used for diagnostic testing, it can be helpful in screening through denser parts or abnormal parts of the breast that the mammogram may not be able to see clearly. Ultrasounds are also helpful for distinguishing between fluid-filled sacs like cysts versus solid mass, as well as can be a guide for biopsies. Breast MRIs can be done as secondary screening tools, as they can help see the exact location and size of any masses. This test can be done if mammograms and ultrasounds come back unclear or abnormal, as well as test to see if there's something non-cancerous showing to create a false net positive reading. Biopsy of the tissue is done if symptoms or imaging suggest that cancer may be present. There are 4 types of biopsy that are commonly used for breast cancer, and they are fine needle aspiration, core needle aspiration, surgical biopsy, and lymph node biopsy. Fine needle aspiration biopsies are often used for fluid-filled sacs like we would see on an ultrasound. In this procedure, they insert a needle, they pull the fluid up in a syringe, and they test it. A core needle biopsy, however, are the most commonly performed when cancer is suspected. In this procedure, they take a large hollow needle and they pull up the tissue through a needle or using a vacuum. This is then biopsied. This biopsy can also be image-based, meaning that they will take anything from the images and use it as a guide on where to go in when they're making the collection. Surgical biopsy may be done as well, where they take out a piece of the abnormal portion called an incisional biopsy, or they take the whole abnormal portion called an excisional biopsy. Lymph node biopsies are used when the cancer has spread or its spread has been suspected. The provider may be able, when they're doing the lymph node biopsy, do a surgical biopsy or vice versa. It's primarily more, if we're doing a surgical biopsy, we may as well do the lymph node biopsy as well. According to Zhu and Diagon, the American Joint Committee on Cancer uses the 8th edition tumor involvement stage for manual staging. This is broken down into T for primary tumor size, N for nodule involvement, M for metastasis, and then a prognosis chart is used along with anatomical staging. TIS stands for in pseudo tumors, followed by T1 and T4, ranging from 2 centimeters to greater than 5 centimeters. When T4 is reached, it is further broken down into T4A to T4D, and these are based if there's chest wall or skin involvement. Next is N for nodules. N0 means there are no regional lymph node metastasis or no lymph nodes involved. And 1 can be level 1 or 2 and describes metastasis to the surrounding pectoral minor borders and axillary lymph nodes. And 2 is described as metastasis to the axillary lymph nodes that are fixed or matted or metastasized to the ipsilateral internal mammary nodes. And 3, however, means that metastasis is present in the infraclavicular lymph nodes, ipsilateral internal mammary nodes with level 1 to 2 axillary lymph nodes, or metastasis to subclavicular lymph nodes. Lastly is M. M0 means no metastasis or deposits, which can be seen on X-rays, is histologically detected. M1 means metastasis is present. M1 is then broken down into 2 categories. CM1 means tumor deposit greater than 0.2 millimeters is detected. M1 means distal metastasis has occurred and the patient is in stage 4 of the disease. Tumor grading is also helpful because it helps us understand the prognosis of patients as high-grade or poorly differential tumors having worse prognosis. This is where that prognosis chart would come into play. They also want to determine hormone receptors because staging with that helps know what kind of treatment we're going to be able to do. ER and PR positive hormones respond better to medications such as tamifaxine used to slow or stop tumor progression. There's other medications out there as well that can help with that. Oncogene HER2 tumors are high grade and are often seen more in IDC than DCIS, however, and that's something that they want to keep in mind. Unfortunately, complications from DCIS or IDC often come from treatment options. Unfortunately, if they are left untreated, that can lead to worsening of the disease and eventually death if left untreated. As we know, cancer can spread very fast, unfortunately. The next slide discusses treatment options and how they can form complications for the patient. In Tomlinson and Hansen's piece, DCIS or IDC is commonly approached within a combination of treatments. Breast reconstruction or a mastectomy are often used to remove the tumor itself. According to the National Cancer Institute, there are 2 types of mastectomies. One is called a total mastectomy or simple mastectomy, where the surgeon will remove the entire breast. The other is a modified radical mastectomy, where the surgeon will remove the whole breast and most lymph nodes under the arm or in the axillary area. In Goethals and Rose, mastectomy can be performed with 3 techniques. 2 of them are with dissection of the area with a scalpel or a scissor technique, and the third is using an energy device, such as an electrocautery, to dissect the breast tissue from the superficial tissue and the posterior attachments of the chest wall. The surgeon then makes an elliptical incision, circumcising the breast, marking the tumor as a central landmark. This includes the nipple areolar complex. Uniform skin flaps are then created by dissecting the superficial layer of the superficial fascia of the breast. Then, the mammary tissue is separated from the skin flaps and is resected from the pectoralis major's fascia to preserve all pectoralis muscle. Here is where, if the patient chooses to have reconstruction surgery at the same time, it happens. Depending on the type of reconstruction depends on what happens next. In skin-sparing reconstruction, a healthy skin envelope is created. In nipple-sparing reconstruction, the surgeon preserves the nipple areolar complex and the entire skin envelope of the breast. Nipple-sparing reconstruction is used for reconstruction happening during the same time as the mastectomy, whereas skin-sparing reconstruction can be done at a later time. Standard general surgery equipment such as general anesthesia, retractors, and to pull the incision open and suction are used during this procedure. Depending on the surgeon's choice, a drain may be placed to help reduce the rate of seroma formation. The patient is then closed and then the healing process begins. During the surgery, a general surgeon or breast oncologist may perform the mastectomy portion of the surgery, and a plastic surgeon will then come in to help create an appropriate reconstruction of the breast. Complications of this surgery include seroma and hematoma formation, wound infection, and lymphedema. The image on the slide is presented from the National Cancer Institute and shows what a total mastectomy would look like before surgery. It also highlights the lymph nodes which can be taken out during a radical mastectomy, just to show you where they would be going into and what they would be taking out. According to the National Cancer Institute, radiation therapy is also used to help treat cancer by killing cancer cells or slowing its growth by damaging the cell's DNA. Once the cells are damaged, there will no longer be able to reproduce and will die, and then the body will naturally take care of the dead cells. There are two types of radiation therapy that are used for local treatment only. The first is the external beam radiation, where a machine will provide radiation by aiming at the cancer in the patient's body. The machine does not touch the patient, but it does move around the patient to hit the cancerous area in many directions. There are three types of beams used in external therapy that all help contribute to treatment differently. Photon beams reach deep in the body and scatter little bits of radiation through its path into the body. These beams are so strong that they actually go through the tumor and into the normal tissue past it. Next is proton beams that give off a positive charge and reach deep into the body to reach the tumor. Unlike photon beams, it stops at the tumor and does not leave radiation pieces in its path, leading some clinicians to believe that it helps reduce the amount of normal tissue affected by radiation treatment. Lastly, there are electron beams that are negatively charged and are limited to tumors near the surface of the body or on the skin, as it is unable to reach deep into the body. There are several types of external radiation therapy. However, there are two more broad types. One is the 3D conformal radiation method that uses multiple types of images to precisely plan the treatment area. Once the area is planned, it is conformed to the shape of the tumor to hit the tumor from multiple angles. The second type is an intensely modulated radiation therapy that is like 3D conformal radiation but using smaller beams. For most radiation therapy, for external ones, they have treatment once a day, typically Monday through Friday. However, each patient is different. The second type of therapy is called internal radiation therapy, also known as brachial therapy, where the source of radiation is actually placed inside the patient's body. In this therapy, the doctor will place a catheter or an applicator so the radiation has a place to go in the patient's body before the treatment starts, and then they will begin the radiation portion of it. There are three types of brachytherapy. Low-dose rate brachytherapy implants the radiation source in the patient's body for 1 to 7 days. High-dose radiation implants, however, are left in place for only 10 to 20 minutes at a time and then are taken out. The high-dose radiation therapy happens multiple times a day for 2 to 5 days, or can be done once a week for 2 to 5 weeks, depending on the cancer type and treatment course. Lastly are permanent implants. Permanent implants, the radiation source is placed into the patient's body and the catheter is removed or the applicator used to put it in. The implants will stay in the patient's body for the rest of their life. The radiation will slowly get weaker every day and eventually almost all of it will be gone. These types can be difficult as patients need to limit time around other people after the radiation is first placed, as the radiation can be harmful for others to be around the patient, such as children or pregnant women. Brachytherapy, regardless of type, will make the patient a radiation source, making safe measures for staff and visitors extremely important. Some measures used will be limited time in the room, not entering the room all the time and staying at the doorway, a private room in hospitals, not entering the room when the radiation is first placed, and wearing protective clothing. Because of these precautions taken with brachytherapy, it can be difficult on the patient and make them feel very isolated. In an article by Aring, researchers discuss how nursing interventions may be the biggest key to helping breast cancer survivors with their sexual health. Sexual health is a difficult topic for most people and especially hard when it comes to the effects of cancer treatment. A multi-module approach is recommended, meaning multiple treatments at once to help treat the issue. This article discusses how psychosocial counseling for patients and couples of cancer survivors is the leading way to help survivors get through the barriers related to intimacy, such as body image issues. Medications are also paired with the counseling to help with physical symptoms such as vulvovaginal symptoms, which could be vaginal dryness or other sources. Nurses aren't comfortable with discussing this topic enough with patients and need to learn to be better to communicate and educate their patients about sexual health. Bringing the topic up to patients can be difficult, but by providing an opportunity for the patient to ask questions and discuss these issues is an important aspect of education for patients. Patients and families should also be handed pamphlets and or website information for counseling before surgery, right after the surgery, and in treatment centers for this. Thank you for listening and or reading my presentation for the ductal carcinoma breast cancer. I hope that this presentation brought new insight into the disease and how it affects patients and how to treat it. These last couple slides here in the slideshow are my references, and I hope that you look into them more.